Welcome, Dr. Anand sir, from I think Trichy. I think Vignesh also joined. Vignesh, good evening.
Hi, good evening, sir.
Good evening, Vignesh. Start பண்ணலாமா? We will.
Yeah, sir, shall we start, sir?
Yeah. You can start.
Next testing you can open for delegates.
Yeah, 1 minute, sir. Sir, we are live. Over to you.
Yeah, thank you. Shall we start, sir?
Yeah. Please proceed.
Thank you, sir. Thank you. Good evening, doctors. On behalf of Alchem Laboratories, India's fifth largest pharmaceutical company, I am Balaji. Take great pleasure in welcoming all the eminent doctors who have joined us for today's panel discussion. Doctor, today's panel discussion will be on vildagliptin, titled Views on Vildagliptin. Doctor, at Alchem, it has always been our endeavor to partner with healthcare professionals, and we will continue to do so even in these challenging times. To help us to navigate through the entire meeting, we have with us today Dr. S. Sridhar sir, who will be our moderator for today's panel discussion. Welcome, sir. I take this opportunity to give a short introduction about moderator and all the panelists. Let me take this opportunity to give a short introduction about our moderator, Dr. Sridhar sir. Dr. Sridhar sir is an associate professor at, and in the Department of Endocrinology and Metabolism at Madurai Medical College. Doctor is also a visiting consultant at Padamalayan Hospital, Madurai. Doctor has completed his MBBS in the year 2004 at Madurai Medical College and MD post-graduation in the year 2008 at JIPMER. And he has completed a super specialty DM.
Actually, make it small and bigger.
Yes. In the year 2012. So with this short introduction, welcome, Sridhar sir. Welcome, sir.
Thank you.
I take this opportunity to welcome all the panelists. Let me first take this opportunity to welcome Dr. Hemnath sir. Hemnath sir is a senior consultant nephrologist who is currently practicing at Padamalayan Hospital, Madurai. Welcome, Hemnath sir.
Hello.
Take this opportunity to welcome the next panelist, Dr. Syed Sultan sir. Dr. Syed Sultan sir is a senior consultant physician and diabetologist who is practicing at Kambam. Welcome, Syed sir. Let me take this opportunity to welcome the next panelist, Dr. Anand Subramaniam sir. Anand Subramaniam sir is a senior consultant interventional cardiologist who is currently practicing at Kaveri Heart City, Trichy. Welcome, Anand Subramaniam sir.
Thank you.
Take this opportunity to welcome the next panelist, Dr. Vignesh sir. Dr. Vignesh sir is a consultant endocrinologist who is currently practicing at Dr. Vignesh Endocrine and Diabetes Center, Trichy. Welcome, Vignesh sir.
Yeah. Good evening, everyone.
With this short introduction of a panelist, I will hand over the session to our moderator, Sridhar sir. Sir, over to you, sir. You can set the context for the webinars.
So good evening, respected physicians, those who are watching this program, and as well as my dear panelists. At the outset, I would like to thank the Alchem team for this program. So this is basically regarding the panel discussion. So it won't be like monotonous way in a PowerPoint slide. So it will be just question answer sessions and the discussions regarding the combinations therapy, and particularly the DPP-4 inhibitors and metformin. And basically, the main focus is the VERIFY trial, even though it was published some 2 years back in the Lancet. And how it is practically, it will be more useful in the day-to-day clinical practice, and regarding where to apply, and how the message from the VERIFY trial is being carried to the translating into the clinical practice. All the things we are going to discuss into the panel discussions. So by starting the discussions, so any type 2 diabetes mellitus, whenever the patients comes to you or comes to us, we have to focus about the dietary habits and lifestyle modifications like physical activity, or like sleep patterns in multiple things. And then only the pharmacotherapy comes into the pictures. And whenever you are choosing the pharmacotherapy, there are various ways what drug we have to choose or we have to prescribe, and what are the basics that behinds in choosing the therapy. So whenever we comes to the pharmacotherapy, we can start with monotherapy, or we can start with the combinations therapy. So with this context, and I will request Dr. Syed Sultan sir. He is a senior physician and retired joint director of health services from Kambam. And sir, what is your opinions regarding the monotherapy versus combinations therapy of oral anti-diabetic drugs in the diabetes management, type 2 diabetes management? Over to you, sir.
Good evening, everyone. At the outset, I thank Alkem for the chance to participate in this program. Yes, see, the UKPD study, it found monotherapy was inadequate and needed additional drugs by about 50% by 3 years and 75% by 9 years. The VERIFY study shows early intervention with a combination of vildagliptin and metformin. It provides greater efficacy and durable long-term benefits compared to metformin monotherapy. The EDGE study also, it demonstrates vildagliptin, in addition to another oral anti-diabetic drug, it lowers HbA1c to target without much side effects. That is, the combination is very effective and well tolerated. So the various studies have demonstrated combination therapy is superior, benefits are long durable without much side effects. So combination therapy, combination of oral anti-diabetic drugs is better than a monotherapy with metformin.
So any other panelists wants to add, Dr. Hemna sir, Dr. Vignesh?
I agree with the previous speaker. I would like to point out when a patient present with the, when we come across a newly diagnosed patient with type 2 diabetes mellitus, when the HbA1c is quite high, though the VERIFY sale trace, even we can start combination therapy when the HbA1c is between 6.5 to 7.5. But many of the treating physicians may not agree with this in a research poor setting. But what I would like to convey is when the HbA1c is quite high, like more than 8 or 9, and when the patient does not have any severe symptoms of osmotic symptoms, then we can straight away start with combination therapy. We need not start with the one drug metformin and wait for the HbA1c next 3 months to start a second drug. So, so that is one opportunity when we can directly start a combination therapy. Either first, so obviously for obvious reasons, we all know metformin is the first drug. So can be metformin can be combined with various sets of drugs. So we all know there are various benefits of adding early DP4 inhibitors in terms of lesser weight gain and non-hypoglycemia. So many of our patients do come with a higher HbA1c, not like they don't come for early screening. So whenever they come with a sugar of random sugar of 300, HbA1c of 8 or 9, so I would prefer to start a combination therapy. So So that would be probably the right time to start combination therapy in our settings. And I need not worry about hypoglycemia. Many times our patients will be in a state of glucotoxicity. Whenever we start a drug, suddenly the sugars crash. Next time when we see the sugar fasting at 70 and postprandial 90, so this also very commonly happens in our practice. So if we, in which case, if the patient is on sulfonylurea, then they may be getting a recurrent hypo symptom. So starting a DPP4, if the so now DPP4 is off patent, Vilda is off patent, it is available at a cheaper cost. So it's easier to start a combination therapy when the patient's HbA1c is quite like 8 or 9. But if they're present with the severe asthmatic symptoms, definitely adding on insulin the earlier would be a better choice for obvious reasons. So I would like the other panelist opinion on this.
Dr. Hemna, sir,
When I see patients with CKD, I think we have very limited choice of drugs. Yeah, we usually see it at an advanced stage when the GFR has dropped below 30. So obviously, we may not be able to use metformin, and the oral drug of choice would be DPP4 inhibitor plus insulin when the GFR is less than 30. But if the GFR is more than 30, we still use metformin and the DPP4 inhibitor. And if the patient is a younger patient and has a better GFR, we would prefer SGLT2 inhibitor along with metformin and then add on DPP4 inhibitor.
yeah. Dr. Anand Subramaniam, anything you wants to add it?
Good evening. From a cardiologist point of view, I think I agree to whatever the previous speakers have said. But most of the patients who come to the cardiologist for a diabetic-related CV disease have advanced, have a long-standing diabetes. So and nearly 99% of them would be on polypharmacy. Apart from the cardiac drugs that they are receiving, they may be compelled to be on more than metformin. So in our practice, in my practice at least, almost all the patients require at least a combination therapy to start with. A single drug may not suffice. So it's well known that though reduction of glucose alone doesn't translate into a reduction of macro events, but still at least further on microvascular events are reduced by at least further A1C reduction. So definitely I would pinch for a early combination therapy than a monotherapy, and most of our patients, cardiac patients, would need combination therapy upfront.
So summarizing the monotherapy versus combinations therapy in our day-to-day practice, many of our patients, they used to present at HbA1c of around 8 to 9. So in such situations, the combinations therapy is always better. And so the ultimate aim is we are targeting two different pathways, because type 2 diabetes is a polygenic inheritance with multiple pathophysiological mechanisms. So we are targeting the insulin resistance at one end, and beta cell dysfunctions or secretory defect, and we may target the liver or kidney or skeletal muscles in such a way. So the combinations therapy always is better, and we are getting the yearly control and maybe a intensive control with targeting different pathways, maybe a single pill or maybe the two different pills. So the combinations therapy always will hold good for many of our type 2 diabetes populations. So with this background, we have a lot of oral anti-diabetic drugs in our the practice, maybe a metformin or maybe a sulfonylurea or maybe a DPP4 inhibitors and SGLT2 inhibitors, and rarely there may be a thiazolidines and chloroquine. So the list is long. And among the thing today we will be discussing regarding the DPP4 inhibitors. And DPP4, it's not a new drug. It was launched, I think, around 2007, and almost 13, 14 years they are available in the market. And so basically, DPP4 inhibitors, it targets the insular axis. So whenever we took food, there is a glucose-dependent insulin release from the GLP. So GLP is releasing from the intestines, and it is a very short-acting. So DPP4 is basically prolonging the duration of action of GLP-1 so that we can get the insulin secretory functions. So that is it work only when there is the glucose into the system. So it is a glucose dependent insulin secretions that is the main mechanisms of DPP-4 inhibitors, and we have some around 4 DPP-4 in our clinical practice. So with this background, I'll be moving into the trial that is a verified trial. And verified trial, it was published around 2 years back in the Lancet. So I would request Dr. Anand Subramanian regarding the verified trial, the background data, and over to you, sir.
Yeah. This verified trial is basically a trial which was done for proving that early initiation of combination therapy is as good as or better than monotherapy with metformin. So this was published in 2019 in the Lancet, earlier presented in the AASD 2019. So basically it's a randomized double-blind parallel group study involving multiple centers, close to 254 centers from different countries. 34 countries were involved. So the trial was done in newly diagnosed type 2 diabetes patients. So the run of the trial was like this. So there is an initial 2-week screening visit, and followed by an initial 3-week of a metformin run-in. Only metformin is given to all the patients, and thereafter patients are randomized into a 1:1 fashion into 2 arms. So the study duration is for a period of 5 years, and during the study period, so they are split into the further study period is split into 3 groups, split 1, 2, and 3. So the patient's inclusion criteria would be anyone between the age of 18 to 70 years, type 2 diabetes with a diabetic age of less than 2 years. So newly diagnosed diabetes, diagnosed within the previous 2 years prior to enrollment. And A1C, the inclusion is between 6.5 to 7.5. And BMI should be between 22 to 40 kilogram per meter square. The randomization is 1:1. Early combination therapy with metformin, that is metformin plus vildagliptin on one side, and on the other side you have initial metformin monotherapy with a placebo. So in study group, you have the early combination therapy wherein the metformin dose is either a stable daily dose of 1000 milligrams or 1500 milligrams or a 2000 milligram dose plus vildagliptin 50 milligrams BID, versus the standard of care. On the other side, you have the metformin monotherapy, wherein the metformin dose is 1000 or 1500 to 2000 milligrams, and with the placebo given in a BD dose. So the study was designed in such a way that if the initial therapy actually did not meet the first endpoint of keeping the A1C less than 7, that means if the A1C remained above 7 on further 2 visits, which were done 13 weeks apart. So the A1C on follow-up remained above 7%. Then those patients who are actually on metformin monotherapy, they would receive vildagliptin, 50 milligram BID along with metformin instead of the placebo. So that is the switch over. And so this is the first study in period. The split 1 is the first study period, where in the first 13 weeks, they are studying 2 HbA1c levels. If the levels remain above 7%, so those who are on metformin monotherapy get switched into the combination group, and they enter the study, they enter the second part of the study. So the primary endpoint is actually time from randomization to treatment failure. So that was studied as the primary endpoint. So treatment failure is A1C remaining above 7%. So the full analysis set included those patients who received at least 1 randomized study medicine and at least had 1 post-randomization efficacy parameters assessed. So this is the inclusion of the verified trial data and the study design and the duration. The duration of the study was 5 years.
So summarizing, it is a very good study, and it was done as a 5 years period. And newly detected type 2 diabetes they have included, and it is a study designs was wonderful. It is a RCT, randomized control trial. One end is both drugs, and another end is a metformin versus placebo. So with this background, what was the outcome and what was the result of verified trial? It will be discussed by Dr. Hemnath, sir. Yes.
So basically the Verify trial was designed to determine whether the clinicians should start with monotherapy with metformin as suggested by ADA in the previous guidelines, or to start with the combination therapy when with vildagliptin and metformin. As the previous speaker told, it was designed for 5 years. Patients were recruited for 2 years. Almost 2,000 patients were recruited from 34 countries. 998 patients were in the combination therapy and 1,001 patients in the monotherapy arm. The patients were 18 to 70 years old and a newly diagnosed diabetes. That is, as previously pointed out, the diabetic age was less than 2 years. And the range of HbA1c was between 6.5 and 7.5. So the primary outcome was the primary treatment failure was defined as HbA1c persistently more than 7% at 2 consecutive visits, 13 weeks apart. And the secondary outcomes were the progression of HbA1c, how it progresses, the rate of loss of glycemic control over time. That is a secondary treatment failure. That is to assess the glycemic durability and to see the progression of the fasting plasma glucose. And number 3 was the change in HbA1c based on the baseline characteristics and to assess the safety and tolerability. So the results see about 80% of patients in each group completed the 5-year period. And in the metformin group, more number of patients, that is 43.6% of patients. The treatment failure was around 36 months in the monotherapy group, but treatment failure didn't happen in the treatment period of 6 years, 5 years, that is 6 months in the combination therapy. There was the risk of treatment failure was 49% lower with the initial combination therapy than with monotherapy. So both the treatment approaches were safe, but to maintain the glycemic durability, a combination therapy was preferred over the monotherapy. That was the conclusion of this trial.
So by 5 years follow-up, the combinations therapy, many people, they have retained the good glycemic control with a long-term glycemic efficacy, otherwise known as the durability. And so regarding the durability, I would ask Dr. Vignesh, what is the meaning of durability and how to position the vildagliptin molecule in the question of durability. So over to Dr. Vignesh.
So to mean in simple words, durability means, so percentage of patients could be able to maintain the HbA1c in long term. So in simple words, how long the oral hypoglycemic agent could be able to maintain the sugars and HbA1c within the target range for the concerned patient. So obviously we all know the diabetes is a progressive disease. There will be a progressive decline in number of beta cells and beta cell function. So over a period of time, the patients may require add-on therapy for glycemic control. Sometimes, many times they land up with insulin for glycemic control. So how long these OHs could specific oral hypoglycemic agent could be able to control the sugars for a specific set of population that would durability. So Verify trial clearly shows vildagliptin has a better combination with the metformin as a durability. So though it is not a completed trial, so when we want to say that oral hypoglycemic agent has failed, at least 50% of patients who are already on a specific oral hypoglycemic agent should have a HbA1c more than the target HbA1c. So still in the Verify trial till 2020 or 19, they say almost 62% of patients could be able to maintain the HbA1c. So it's not a completed trial, so it's still ongoing data. So these studies clearly show the metformin with vildagliptin has a better durability in terms of keeping the HbA1c within the desired target range. So compared with this was compared with the metformin monotherapy.
So basically, this durability, the terminology were used for ADAPT study or rosiglitazone when it was launched into the. So far in available oral antidiabetic drugs, the durability is more still applicable for the glitazones, particularly it was rosiglitazones, and because of this various side effect, it was withdrawn from the market. And so among next to the other available oral antidiabetic drugs, this is the verified trial that was the vildagliptin and combinations that shows or that has spoken about regarding the durability or long-term efficacy of one particular agent. So by translating into the clinical practice, any drug, if you are using combinations and if you are control yearly or intensively to keep the HbA1c around 6.5 to 7, it will work for a longer run, maybe a sulfonylurea also. And so our aim or our motivation should be to make the patients are intensive or early glycemic control, so that any drugs it will work for a longer run. And so this is the scientific evidence or data that shows the long-term efficacy of the vildagliptins and metformin and with the existing therapy. So with this thing, moving into the next discussions regarding, there are a lot of gliptins are available in the market, and I would request Dr. Sayer sir regarding how do you see the vildagliptin versus other gliptins available in the markets? Over to you, sir.
Although there are some practical differences between the different gliptins with respect to dosing frequency and their ability to be used in different subpopulations and cost, there seems to be little to distinguish between them in terms of their efficacy as anti-diabetic agents and their safety. So several RCTs with CVOT on DPP4 inhibitors, they reported neutral effects on the composite major adverse cardiac events endpoint. But with saxagliptin, there is increased the risk of heart failure hospitalization, though no increase or decrease of ischemic events. So yet some meta-analysis showed 100 mg of sitagliptin was slightly inferior to 100 mg of vildagliptin in DPP4 inhibition. In practice, after the price reduction and vildagliptin is affordable for almost all classes of people, I prefer vilda as the first choice of DPP4 inhibitor.
Yeah. So we have sitagliptin and vildagliptin both were launched at the same time, and subsequently saxagliptin and alogliptin and teneligliptin, and so these are the commonly available gliptins. And because of the increased risk of heart failure, the saxa, they are not preferred in individuals with the high risk of cardiac failure or other thing. Otherwise, all other gliptins currently in the neutral positions, that is the thing. And the cost-effective analysis we will be discussing in the later slides. And regarding the next the questions to all the panelists, what is the positions of add-on therapy of vildagliptins in additions to the existing metformin, sulfonylurea, agility inhibitors, and insulin? So where can positions the add-on therapy of vildagliptins in additions to the existing therapy? So over to Dr. Anand.
Vildagliptin and in my practice, in cardiac practice, generally is used in patients who have been already on metformin or sulfonylureas, where they have exhausted 2 OADs and still the A1C remains above target. So we add vildagliptin. Especially it is used in patients who don't need weight gain. So it's a weight neutral agent and doesn't cause much of hypoglycemia. So in particularly in elderly cardiac patients, long-standing diabetics who are prone for recurrent hypoglycemia, so this is a good agent. So vildagliptin is preferred upfront over sulfonylureas or insulin. Though insulin, I'll leave it separately. Among the OADs, vildagliptin is supposedly hypoglycemia neutral as well as weight neutral. So those patients who are actually obese, elderly patients, and in CKD, vildagliptin is preferred combination therapy along with metformin than other sulfonylureas.
Yeah, Dr. Vignesh, regarding the vildagliptin with insulin, what is your position?
So vildagliptin with insulin. So my clinical practice is whenever I start insulin in the patient with the secondary OHA failure, by going by our clinical knowledge, so we all discussed already the gliptins work by beta cell dependent insulin secretion. So when the patient is insulinopenic, so I generally go only with insulin and metformin in most of my prescriptions. Very rarely I use sulfonylurea or gliptin with the insulin. So for obvious reasons, when the secondary OHA failure occurs, obviously when there is no beta cells left, so my clinical practice is I generally go with insulin plus metformin.
Dr. Hemnath sir, your comments.
For us in CKD, we have a limited number of drugs to use, particularly with sulfonylureas because of the risk of hypoglycemia. So what I used to do is, if the patient tolerates metformin well, I add on vildagliptin before sulfonylurea. And if they are not controlled, I add sulfonylurea, specifically 1 milligram of glimepiride or glycoside. Very rarely I use glipizide because it has to be given twice a day because of the complaints. Because already we have a lot of drugs to use in CKD. So in order to maintain compliance, I prefer a single daily dose of drug. In CKD, we have to reduce the dose of vildagliptin as well as metformin. So we can give it as a single dose therapy. And if they are not controlled with sulfonylurea and metformin and vildagliptin and DPP4 inhibitor, what I do is I'll add on insulin and withdraw sulfonylurea to prevent hypoglycemia. Because the absorption of sulfonylurea in CKD is very erratic, particularly when they have a gastroparesis also. Many times the CKD patients will have a poor appetite and the absorption will be of sulfonylurea will be very erratic. So I keep DPP4 inhibitor and insulin. If they tolerate metformin, I'll continue metformin.
So summarizing the evidence, we can use it with any combinations like metformin, like we can use it in sulfonylurea, and in selected patients, whenever the patient's requirement of insulin is very high and not tolerating the metformin or any glitazones or contraindications to use metformin and glitazones, we can use along with the insulin. Whenever indirectly it may reduce the dosage of insulin requirement. That is the one options. And recently it is being used along with gliptins and SGLT2 inhibitors also. So it is since it doesn't cause hypoglycemia and it is weight neutral, we can use it with any agents available along with the things. That was the current situations in our practice. And moving on to the next question, that is one of the study that is from the Indian study that is named as a EDGE study. And so I would request Dr. Vignesh to share some knowledge or lights from the EDGE study.
The EDGE study is basically a Indian study. It is an open label study. It's a basically 1 year follow-up of 11,000 patients in various centers across India, around 400 centers. It is a post hoc analysis. That is, they analyze the efficacy and adverse effects of the drug. So basically, it compares vildagliptin with any other agent, any oral hypoglycemic agent. It can be a metformin or a sulfonylurea or a thiazolidinedione with any two other agents. So other than vildagliptin, any two agents. So most common in this study, when we see the most common two agents in vildagliptin, 75% of patients with the vilda were on metformin. So first most common combined agent. The second is those who are intolerant to metformin. These patients were on sulfonylurea or vildagliptin. Other oral hypoglycemic like agents like thiazolidindiones or alpha glucosidase inhibitors are definitely low numbers to say. In the comparator group, when we say they compare most common combination in the comparator group is metformin plus sulfonylurea, which is very common in our clinical practice. So they compare these two groups, the vildagliptin plus any OAD or any two other OAD, to see the efficacy and the adverse effects. The primary endpoint is HbA1c reduction more than 0.3%. Why this 0.3% is clinical relevant HbA1c reduction should be 0.3%. So how much efficacy these agents, combination agents, could able to produce clinically relevant HbA1c reduction without any significant adverse effects. Adverse effects meaning edema and weight gain and RGA intolerance. So they found the vildagliptin with any oral hypoglycemic agent, but in the study most commonly it is combined with metformin and less, and 75% of patients, and other 20% it's sulfonylurea. So combined with these agents could able to get a good HbA1c reduction, that is more than 0.3% when compared with that of other any two agents. So it is numerically high, maybe over 10 or 20% higher. And compared to the secondary endpoint, adverse effects, the patient developing hypoglycemia. So those patients who are on good glycemic control, that is HbA1c less than 7, developing a hypoglycemia or weight gain. Weight gain means clinically significant weight gain, that is more than 5%. So obviously those patients, the vildagliptin metformin combination group have lesser hypoglycemia and weight gain compared with any two OAD. The other group we already know, this is sulfonylurea is there, which is we all know sulfonylurea can cause hypoglycemia and definitely weight gain. So obviously it's an Indian study. They concluded vilda with any OAD is efficacious in bringing down the HbA1c with the lesser adverse effects, and vilda with the metformin has a lesser risk of hypoglycemia and weight gain. So this is an Indian study. There is one more study. It is a post-hoc analysis, which is a continuation of this study. They compared with the only sulfonylurea group also. They compared with the sulfonylurea plus vildagliptin in which patients, when the patients are intolerant to metformin, they still found these patients could able to achieve a good HbA1c reduction and with lesser side effects. So it is in a nutshell, I would say vildagliptin with any in bringing down the sugars, in bringing down clinical reduction, clinically relevant HbA1c reduction with a lesser risk of hypoglycemia and weight gain.
So any oral drugs, if you are using at the early stage of time, the HbA1c reductions may be expected around 1.5 or 2%, maybe a combination therapy. And whenever you are initiating any drugs and late at the stage of diabetes, like more than 5 years of duration, we may not expect that much amount of HbA1c reduction. So it means that is a progressive beta cell dysfunctions, and many of the times if we looked into the later stage, many of the therapy may not be effective that much amount of enough. So with this background of diabetics is a progressive disease, and if any drugs you are choosing into the practice, one is efficacy, another one is a side effect like weight or hypoglycemic risk, and the third one is maybe the gastric intolerance or bone health or like that. So with this thing, any drug, if it has to be successful in the clinical practice, it should have cardiorenal safety. So if any drug is the renal point, concerning to the renal point of view, diabetes itself can cause progressive decline in the renal functions, probably maybe a microalbuminuria, or later stage maybe a diabetic retinopathy and diabetic nephropathy. And whenever we are using sulfonylurea, there may be the chance of hypoglycemia is there. So with this background of diabetic nephropathy, what is the position of vildagliptins in CKD patients? So over to Dr. Hemnath sir regarding the point.
Diabetic management in CKD is going to be a very tight slope walk. Number one, the assessment of the glycemic control itself is going to be difficult because HbA1c may be fallaciously underestimated in CKD because of presence of anemia, because of use of iron infusions, because of blood transfusions, because of shortened lifespan of RBCs in CKD. The HbA1c levels are often underestimated. So the best way to assess the glycemic control is by continuous glucose monitoring, which is practically not possible. So still, for clinical practice, HbA1c is the gold standard in even in patients also. However, the target for HbA1c is very much varied in CKD patients because of presence of other comorbidities. Number one, age. Number two, most of the CKD patients have an extremely high risk for cardiovascular disease. So in those patients, they may have other macrovascular complications in the form of severe atherosclerotic peripheral vascular disease also, as well as a cerebrovascular disease also. So the control of the diabetics should be individualized, and the target should be between 6.5 and 8. Those who have severe comorbid conditions, those who have impaired the hypoglycemia and awareness, we have to target a higher HbA1c than a tight HbA1c. And the lifespan. In CKD, the lifespan is going to be reduced, particularly when they are on hemodialysis. So you need not control the diabetic very aggressively in those patients. Number two, the risk of hypoglycemia is extremely high in those with the CKD because of, number one, the use of the drugs insulin as well as oral sulfonylureas. Most of them are eliminated by the kidneys, so they accumulate in the CKD and it becomes a problematic for producing hypoglycemia. So we prefer to use those drugs which do not produce hypoglycemia, like metformin, DPP-4 inhibitors, SGLT2 inhibitors. And if the glycerol is not achieved, then add insulin rather than oral anti-diabetic drugs. Like if GFR is more than 30, we can try to use sulfonylureas. And if GFR is less than 30, we prefer insulin. So DPP-4 inhibitors can be used at all the stages of CKD, including dialysis patients, because they are renal safe, but the dosage modification has to be done. Almost all the DPP-4 inhibitors are eliminated by the kidney, except linagliptin. For vildagliptin, you may have to reduce the dose of vildagliptin by 50 milligram once a day is enough. So vildagliptin can be safely used in CKD patients in all the stages of CKD.
So moving on to the next question is regarding the diabetes is one of the strong risk factors for the cardiovascular risk, one of the strong cardiovascular risk in addition to the hypertension or dyslipidemia. And it is more common in elderly as age increasing, the risk of cardiovascularity as well as the peripheral vascular disease that is more common with the elderly and increasing diabetes populations. So with this background, the questions to Dr. Anand Subramaniam regarding the role of vildagliptin in management of diabetic patients in elderly situations. So over to you.
Particularly elderly diabetics have a lot of cardiovascular risk factors and comorbidities, and they are very highly prone for hypoglycemia. So one single factor that we always worry about is that our patients should not develop hypo. Even if the A1C remains above 7.8, we are not that much bothered because no acute event is going to happen with a persistent hyperglycemia than one single episode of hypoglycemia, which can actually kill the patient. So we are all aware of the deathbed syndrome. We are aware that nocturnal hypoglycemia is quite common in patients with sulfonylureas, insulin, etc. So especially in elderly patients, diabetes and cardiovascular disease, hypoglycemia especially can be very severe. And these are the patients who are less likely to identify hypoglycemia and report to us. So the incidence of silent acute coronary syndromes and arrhythmic deaths are quite common in elderly population. So coming to the molecule, vildagliptin. So whenever we write a molecule, we always think about the efficacy of the molecule. So thinking about the efficacy of vildagliptin in elderly diabetics, it is as good as any other younger population. So it is as good as any other molecule to reduce A1C levels when compared to an younger population. So elderly diabetics also have a fairly good A1C reduction with use of vildagliptin. Now coming to the safety endpoints, whether vildagliptin, if put in our elderly cardiovascular patient, is it safe? If you think in that lines, definitely it is safe because it is not going to increase the risk of hypoglycemia. It is actually preferred along with metformin even before sulfonylureas. It definitely thiazolidinediones are not preferred in heart failure patients. So it is a good agent for use in elderly patients with the heart failure, and especially because elderly patients have this particular combination of elevated postprandial glucose as well as hyperglucagonemia. Both the glucagon levels and PPG levels are elevated. Vildagliptin actually addresses both these problems. Vilda, as was told earlier, actually it increases the alpha and beta cell responsiveness to the blood glucose fluctuations. So whenever the blood glucose remains high, the inappropriate glucagon secretion as well as the postprandial glucose excursion is mitigated. Whereas at lower glucose levels, this protective effect of glucagon, thereby preventing hypoglycemia, is actually preserved. So thereby, actually, vildagliptin actually neutralizes the glucose levels at all the glycemic levels. So mitigating hypoglycemia is, I feel, is one and the only advantage and the single most advantage of use of vildagliptin, and it's relatively a safer molecule. And tolerance-wise, I have not seen significant intolerance with the use of vildagliptin in our population. So going by the safety data, efficacy-wise, as well as the tolerance, I think vildagliptin can be safely used in our cardiac patients, and particularly because it doesn't cause that much hypoglycemia. And secondly, it's weight neutral. So even in advanced heart failure patients who have just recovered from a ADHF, so you can use vildagliptin along with the metformin. Even if your patient may be metformin intolerant, I have been using a lot of vildagliptins and other gliptins, DPP4 particularly, in such population.
So if no other parameters or no other risk factors, if unable to assess like renal or cardiac or gastric intolerance, the DPP4 inhibitors, it is quite safely comparing with the other agents because of the lot of neutrality and other benefits. So with this background, the cost effective analysis, when the gliptins was launched in 2007, it was around 40-45 rupees. So it was the cost, one of the major factor preventing the usage of gliptins. And later, around 4 or 5 years back, teneligliptins came into the picture, and it was becoming labeled as a poor man gliptins. And later, around 1.5 years back, the patency has been gone, that vildagliptin was becoming off patent. And there was a lot of generic molecule of vildagliptin has becoming available in the market in our clinical practice. And so the vildagliptin becoming very cheap and effective, and many of the companies, they have the quality of vildagliptins also has been standardized. So with this background, I would request Dr. Syed Sultan sir, how you are looking into the cost effective analysis of vildagliptins comparing with the other gliptins.
Actually, I am practicing in a small town, and most of my patients are middle class and lower class patients. So before the price reduction, the gliptins, I cannot think of using gliptins in those patients, because if I write, as he said, in the elderly patients or patients, they are more prone for hypoglycemia. So if I advise gliptins, the next day he will go to another doctor, or he comes, sir, I cannot afford this much of price. So it was very difficult for us to use these gliptins. Then teneligliptin came, as you said, it's a poor man's gliptin. It was with a reasonable cost. So we started using a teneligliptin very frequently. But but efficacy wise, I feel vildagliptin is much better, especially after the price reduction. Most of my patients, I am using vildagliptin, and they are very effective. especially elderly patients, frail patients. They tolerate very much, and they are the affordable cost. So it is a very useful for middle class and these patients. I think now with this affordable price, vildagliptin is very much used.
So in addition to the affordability, the safety and the long-term data are available comparing with teneligliptins. So comparing the cost-effective analysis, it scores over the efficacy as well as the cost also. Comparing the teneligliptin cost, vildagliptin even twice daily price also is coming less than the single dose of teneligliptin. So it is definitely scores over the cost of teneligliptins. So moving on to the last before one questions is it is not regarding the gliptins, it is regarding the mucormycosis. It is being increasingly recognized in this recent COVID era, even though we have the number of COVID cases has come down, but in diabetic populations or people those who are overly controlled diabetes like HbA1c more than 9 or 10, we are finding increased incidence or increased recognitions of mucormycosis, and Dr. Hemnath is doing a wonderful service of taking care of a lot of mucormycosis patients. And so I would request some thoughts regarding the mucormycosis and COVID managements, COVID recovered patients in your day-to-day clinical practice. Over to you, sir.
Yes, of late we are seeing more and more of mucormycosis following the COVID infection. Likely reason probably is the use of a steroid, which produces more of a new onset and uncontrolled diabetes. And COVID itself is unmasking diabetes also. And with the use of steroids, it becomes very much uncontrollable. That helps in the growth of mucormycosis, because mucormycosis is there everywhere. And when immunity is impaired, it becomes a problem. And it mainly affects the sinuses, and if it becomes severe, it enters the orbit and into the brain. That becomes life-threatening. And one more problem is with mucormycosis, the pulmonary mucormycosis, which can be almost fatal, because they have an angio-invasive property that keeps on eroding the blood vessels, and when it invades the bronchial vessels, and it definitely ruptures and produces massive hemoptysis, which we quite often seen in a post-transplant scenario. But so far in COVID patients, I have seen only one pulmonary mucormycosis so far. And with respect to the treatment, we have two drugs for treatment of mucormycosis. One is the amphotericin B. Unfortunately, the conventional amphotericin B is not available. It is the production itself is less, and probably the lipid complex and the liposomal amphotericin B is available. The only problem is with this drug is the cost. We have to give 5 milligram per kilogram body weight at least for 2 weeks. But what I do is I start using amphotericin B and the other drug posaconazole, oral posaconazole, with a combination therapy in the initial first week or 10 days, and then withdraw amphotericin B and continue with the posaconazole for another 4 weeks. So total duration of the treatment for mucormycosis should be at least 4 to 6 weeks of oral drug with posaconazole. More important thing is we have to go for surgical debridement of the involved sinuses. That will give the better clearance than using drug alone. And what I have seen with the diabetic part is that those who develop a new onset of diabetes, after the treatment of mucormycosis, the requirement for insulin dramatically comes down, and they go for recurrent hypoglycemia. And sometimes the glycemia, the diabetic itself is getting controlled very well with a single agent. That was very much surprising. Those who had a blood sugar of 700 and HbA1c of 11, suddenly, after treatment of mucormycosis, they go on with a single drug, which is really, I don't know how to explain that. So the main stay of treatment is amphotericin B, surgical debridement, and continue with oral posaconazole for mucormycosis.
So if they presented yearly, I think it is manageable very well. Unless the recognition is becoming very late or intracranial extensions or cavernous sinus involvement, it is going to be detrimental. So our the yearly recognitions and proper referral may be better options to save the patients. That is from point of view. And moving to the last part in this, it is the key home message to those audience, those who are involving in this program, in this the COVID era. What is the message to the diabetes and the COVID situations? So start from Dr. Vignesh. Diabetes and COVID, what is the message, and to the general practitioners or those are the audience?
Dr. Hemnath, I ask a question to you. Is there any drug we can use to prevent the mucormycosis, a prophylactic drug, like the oral
No, sir.
in COVID patients?
No, there is no prophylaxis. No prophylaxis.
Only after confirming the mucormycosis, then only we have to.
We can, because they are amphotericin B is nephrotoxic, and posaconazole can produce elevation of SGOT and SGPT. So we have to monitor them closely. And amphotericin B cannot be given as a outpatient therapy. They have to be admitted with the central line. We have to use with frequent monitoring of electrolytes, magnesium, and the renal parameters. So at least 2 weeks, the patient has to be in the hospital for completing the treatment. And with respect to diabetes, I would suggest rather aggressive treatment of glycemia with insulin or whatever drugs are available in the when you are using steroids. Aggressive control alone can prevent emergence of mucormycosis in COVID patients.
Yeah. Yeah, Dr. Vignesh, you want to add it? Anything?
Yeah, my question to Dr. Hemnath, sir. So previously, before this COVID era, I do use both deoxycholate preparation, that is
Conventional.
Yeah, some connectivity issues there with Dr. Vignesh, I think. Yes, last. So Dr. Anand Subramaniam, anything you want to add it, carry home message to the delegates audience?
I think it has been well summarized by you. I would like to add only one thing for diabetes and mucor. It's not only the use of steroid. I think because we all know that COVID is a vasculotropic virus also. So it causes a lot of vascular thrombosis. So microvascular thrombosis at the tissue level causes tissue anoxia or tissue hypoxia, which actually causes the spores to settle and develop. Otherwise, in a non-COVID patient, also getting simultaneously treated at the same time, he is not getting a mucor. And secondly, we are also using a lot of antibiotics in our COVID treated patients. So these two factors also contribute to occurrence of mucormycosis, which has been rampant right. I think that is what I want to add.
Yeah. So Dr. Syed Sulal, anything you want to add it, sir? Mr. Balaji, if any other questions is from the audience or anything is there, what is the?
Sir, there's only one question which has come on vildagliptin and dapagliflozin. Which one is the preferred? So already it is covered, but probably if you want to add any points like in sir. Vildagliptin and dapagliflozin, which one to prefer?
So currently in India, it is not available, vildagliptin with dapagliflozin, but in futures we may expect it. I think they're in the.
Sorry, vildagliptin or dapagliflozin, sir.
So vilda or dapagliflozin. Okay. So the dapagliflozin may be a better options or maybe a preferable therapy in patients with recurrent heart failure or established atherosclerotic cardiac disease. Whereas vildagliptin, we can use it at any point of time. That is the advantage. And so we cannot fit it all the drugs to all the patients. So depend upon the underlying clinical situations and the cost and underlying the comorbidities, factors, and side effect profile that you can choose it. But whenever the cardiac safety and the data wise in CV risk, high risk patients, agility scores also something with this DPP-4 inhibitors. That is the current update of knowledge.
Sir, I want to add another point. See, in diabetic foot ulcers, the gliptins, they are supposed to influence diabetic wound healing and reduce scar formation. There is.
Okay. Vignesh, anything you wanted to add it?
So what about the incidence of pancreatitis in gliptin shoes?
So when it was launched, there was a long debate was there, but then finally it came to the pictures that DPP-4 alone doesn't cause pancreatitis. So in a genetically predisposed individual or with coexisting factors like alcohol or hypertriglyceridemia or hypercalcemia, these are the factors they found to increase risk of pancreatitis. Diabetes per se, they have high risk of pancreatitis comparing with the non-diabetic populations. But already pancreatic diabetes or recurrent pancreatitis or chronic fibrocalculous pancreatitis, better not to use a DPP-4 inhibitor. That is the only the caveat or negative point about the DPP-4 in diabetic prescription. So in lean diabetes or pancreatic diabetes, DPP-4, there is a theoretical risk is there to use it, but we have to balance it and close monitoring if it is using the DPP-4 in but DPP-4 per se doesn't cause pancreatitis. In coexisting risk or underlying diabetes, that may precipitate the pancreatitis. That is the current knowledge about gliptins and pancreatitis. It's a good question, sir. Yeah. Balaji, if no more questions is there, you can deliver the vote of thanks and we can.
Yes, sir. That was the only question, sir. I think all the other points, it has been covered completely by all our panelists. Thank you, sir. So thanks for the opportunity, sir. Before going into the closing remarks, I'd like to share only one slide and on the latest development of vildagliptin, sir. So allow me to present the slide, sir.
Yeah.
Yeah, the slide is visible, sir?
Yeah, visible.
Yeah, sir. Yeah. Sir, Govilda, we had brought 100 mg OD dosage with matrix technology. Once patency got over last year, immediately like company started formulating this OD formulation, and we had done a 3 months trial with the parent company BD dosage. We had tried this DPP-4 inhibition. We had seen the efficacy part. DPP-4 inhibition is almost similar compared with the parent company 50 mg BD dosage, sir. And also we had done the bioequivalency study wherein Govilda OD is bioequivalent to innovator brand. So with this, it clearly says like the efficacy is on par with international brand. And also we have Govilda OD, the cost economical benefit, because Govilda OD is the most economical vildagliptin 100 mg which is available, which is priced at only 10 rupees to the patient. And also Govilda 50 mg is priced at 5 rupees. And Govilda M500 and M1000, which is in sustained formulation again, which is also priced at 6 rupees and 7 rupees. So I request all the panelists and delegates who are attending this meeting kindly take up this brand Govilda and Govilda OD in a clinical practice. So with this, so firstly, I'd like to take this opportunity to thank our chairperson, moderator, Dr. Sridhar sir, for accepting our invitation and moderating the panel discussion today. It was an excellent meeting. You had covered up the entire discussion points on vildagliptin, and I'm sure like all these points will be great helpful for all delegates and clinical physicians who have been participated in today's meeting. And I'm sure all the doctors who will be appreciating the views which has been presented by all our panelists today. Also, I'd like to thank this opportunity panelists, Dr. Sultan sir, Hemnath sir, Vignesh sir, for giving us an opportunity and to conduct this panel discussion. It was a great clinical experience shared by you all, sir, which will be more helpful for all the doctors. I'd like to thank all the delegates for today's webinar. So at this juncture, I like to salute all the doctors and paramedicals who have contributed immensely for keeping us all safe and healthy in these challenging times. So we at Alkem, sir, will continue to serve doctors and patients by making our products available, especially our Glovilda, M, Jupiros, and WorldCom. Thank you, sir. Good night, sir. Thanks once again for the opportunity, sir.
Thank you very much, Dr. Saidi Sultan and Hemnath.
Thank you. Good
Thank
night.
you.
Thank you.
Thanks, sir.
Yes, sir.
Thank you, Syed, sir. Thank you.